Good day. We are Group 1 and together with my co-reporter, Anna Caringal, we are to present parasitic euglenozoans. The phylum Euglenozoa is a diverse group of common marine and freshwater flagellates that contain secondary plastids. Under the parasitic Euglenozoa, we have the Trypanosoma species. Here is the general outline and taxonomic classification of trypanosomes. The name is derived from the Greek trypano, or means borer, and soma means body, because of their corkscrew-like motion. The mitochondrial genome of Trypanosoma, as well as of the other kinetoplastids, known as the kinetoplast, is made up of a highly complex series of catenated circles and mini-circles and requires a cohort of proteins for organization during cell division. The phylogeny of Trypanosoma, according to Joice et al., suggests that it is not monophyletic. As a quick review, a monophyletic group is a group composed of the most recent common ancestor and all of its descendants. However, phylogenetic analysis of 18 sRRNA genes have failed to provide evidence for the monophily of the Trypanosomatidae family, resulting in two distant taxonomic clades, the American and African trypanosomes. But when other protein families were analyzed, it contradicted the phylogenetic analysis of 18 sRRNA sequences, thus supporting the monophily of the two distinct clades. Phylogenetic analysis from Hamilton et al. Supports the monophily of trypanosomes. Genes for glycosomal glyceraldehyde phosphate dehydrogenase and small subunit ribosomal RNA support the hypothesis that trypanosomes evolved from an ancestral insect parasite that adapted to a vertebrate or insect transmission cycle. This implies that the switch from terrestrial insect to aquatic leech vectors for fish and some amphibian trypanosomes were secondary. Humans would be the common reservoir host for trypanosomes, but other hosts can also be mammals such as primates and cattle. And the vector species known are the tsetse and kissing bugs. There are 8 common species of trypanosomes, either found in the Americas or in Africa. First is the American Trypanosoma rangelii, which can be transmitted to humans as non-pathogenic, but it is medically important as a source of misdiagnosis of Chagas disease, which will be discussed later. The next two are Trypanosoma evansii and Trypanosoma equiperidum. Both lack kinetoplast and they both infect horses. The difference between the two is that evansii is transmitted through mechanical transmission by the blood-sucking flies, while equiperidum is transmitted through the intercourse of its host. On the other hand, both Trypanosoma congolens and Trypanosoma simiae are found in Africa. These also infect terrestrial ungulate animals, or in other words, hoofed herbivorous quadruped mammals. As for the Trypanosoma simiae, it is host-specific for the pigs. Last but not the least, we have Trypanosoma cruzi, which is found in the Americas. It utilizes blood-sucking triatoma or kissing bugs as vectors to infect humans and other mammals. Following the life cycle of an African trypanosome, first it starts when an infected tsetse flies bites on a mammal and injects metacyclic trypomastigotes into its skin tissue. Number 2, the parasite enters the lymphatic system, and it will turn into bloodstream trypomastigotes, which would infect other sites. Third and fourth, it will replicate by a binary fission and invade other sites and body fluids. As for the fifth step, a tsetse fly will take a blood meal and becomes infected with trypomastigotes. In the fly's midgut, the parasite will start to transform into procyclic trypomastigotes, then into epimastigotes, and further multiply. Lastly, number 8, once the epimastigotes reach the fly's salivary glands, They will continue to multiply and repeats their cycle by infecting mammals and humans with the blood meal of the tsetse fly. Now for the epidemiology of African Trypanosoma. Subspecies gambiense is pronounced in the western part of the continent, while subspecies rhodesiense is common in the eastern and southern regions. Most infections were observed in humans, as well as domestic animals such as cattle. African trypanosomes can induce African trypanosomiasis, or sleeping sickness, which is transmitted by infected tsetse flies. Untreated infection may cause damage to the nervous system. Infection can be chronic or acute. Chronic conditions develop slowly or worsen over an extended period, while acute infections occur rapidly or immediately. Initially, the disease is characterized by fevers, headaches, itchiness, and joint pains, beginning 1 to 3 weeks after the bite. Weeks to months later, the second stage begins with confusion, poor coordination, numbness, and trouble sleeping. Acute infections by Trypanosoma brucei and rhodesiense may suddenly invade the central nervous system, which can be fatal. The risk of having sleeping sickness is high when tsetse flies originating from forests and streams occupy the rural areas. They bite mostly during the daytime, and both male and female flies can transmit the parasite. Transmission can also happen during the gestation period through blood transfusion, transplantation, and other laboratory exposure. Treatment of African trypanosomiasis depends on the subspecies and stage of infection. Antiparasitic drugs such as pentamidine would be effective against the first stage of Gambiense infection. To prevent such infections, insect repellents can be used to avoid tsetse flies, and one can wear long-sleeve clothing with neutral colors to prevent insect bites. Now let's look at the life cycle of an American trypanosoma. To start, an infected kissing bug performs a blood meal and releases trypomastigotes in its feces beside a nearby bite wound. Therefore, the infection follows the contaminative method wherein the parasite enters through a wound opening from the feces. Second, trypomastigotes will penetrate cells that are close to the inoculation site and differentiate into several intracellular amastigotes. Third and fourth, amastigotes will multiply by binary fission and will differentiate into trypomastigotes. These will be released into the bloodstream, and trypomastigotes can infect cells and transform into intracellular amastigotes in new infection sites. At this stage, the host manifests clinical illnesses. Although the bloodstream trypomastigotes do not duplicate, replication will resume once the parasite enters another cell or is ingested by a new vector. Fifth, a kissing bug performs blood meal and ingests trypomastigotes and turns into epimastigotes in the vector's midgut. Next, the parasite differentiate and multiply in the midgut, and lastly differentiate into infective metacyclic trypomastigotes in the hindgut. Infection of an American trypanosomes is endemic throughout the Americas. As seen in the figure, South America had the greatest number of infections from humans and mammals since vectors proliferate in the wildlife reservoirs, such as the Amazon. Now, when infected by an American trypanosome, it can cause Chagas disease, and it also has two phases, the acute and chronic phase. The symptoms change over the course of infection. In the early stage, symptoms may include fever, swollen lymph nodes, headaches, or swelling at the site of the insect bite. After 4 or more weeks, untreated individuals will enter the chronic phase of the disease, like heart disease, digestive complications, including an enlarged esophagus or an enlarged colon, and may experience nerve damage. To treat American trypanosomiasis, antiparasitic medicines are paramount to eradicate the parasite, while symptomatic treatments would help patients recover from signs and symptoms of infection. Although there is no vaccine for Chagas disease, we can prevent infection by using insecticides against kissing bugs and maintaining community cleanliness paired with personal hygiene. As for transfusions and transplantations, thorough screening is required to avoid parasitic transmissions.
Another genus under the phylum Euglenozoa is the group of obligate intracellular protozoa Leishmania. Similar to the flow of discussion on Trypanosoma, we will be talking about the following aspects of this disease-causing parasite presented here. Leishmania is considered to be an understudied genus, and as a consequence of this, there are no established criteria for species definition nor a method used for addressing its phylogenetic classification. It was initially reported in the late 1900s that there are a total of 5 subgenera and complexes, classified according to the form of disease cause and its distribution, both of which will be discussed later. However, only 3 out of 5 subgenera are now currently accepted with the emergence of molecular data. In terms of Leishmania evolution, it is said that according to fossil evidence, this group of protozoans co-evolved with its sandfly vectors, albeit more closely than its vertebrate host. The genus itself, on the other hand, diverged from a trypanosomatid line of monogenetic insect parasites, based on evidence from small subunit ribosomal RNA. Lastly, a major force of evolution of Leishmania is the commonality of gene expansions. Major species-specific expansions in genes mediating host-parasite interactions gave rise to this parasite's genome complexity and enabled it to cause a wide spectrum of diseases caused by different Leishmania species. The host of this parasite can either be animals or humans, and may be zoonotic or anthroponotic depending on whether it is transmitted from an animal to a human or a human to a human through a vector. It was briefly mentioned earlier that Leishmania is transmitted via the bite of a sandfly vector. As of now, there are only 2 confirmed genera of sandflies that can be infected by this parasite, the Phlebotomus and the Lutzomia. Currently, approximately 53 species of Leishmania have been described. These species may be categorized into Old World or New World species. Old World species pertain to Leishmania species that can be found in Africa, Asia, and Europe, while New World species are those that can be found in North, Central, and South America. Here are representative species of Old and New World Leishmania that can cause different forms of human disease. The disease caused by the infection of Leishmania is known as Leishmaniasis and is classified by the CDC as a neglected tropical disease. It is a vector-borne disease commonly transmitted by female phlebotomine sandflies. It generally affects the poorest population due to poor lifestyle conditions, making them more vulnerable. It was also found that this disease is linked to environmental changes, such as urbanization, where human incursion into forested areas increases the risk of zoonosis. Note that, as previously mentioned, there are 3 general forms of Leishmaniasis depending on the species of Leishmania infecting the host. The first form is known as cutaneous Leishmaniasis. This is the most common form of this disease, and clinical symptoms such as skin lesions and sores will usually manifest within a few weeks or months of the sandfly bite. The lesions are commonly painless but may become painful when swollen glands develop near the sores. However, do note that there are cases where infected people are asymptomatic. The second form is visceral Leishmaniasis. This form affects several internal organs, hence the term visceral, and can be life-threatening. Symptoms can reach up to months or years of the sandfly bite before arising. Lastly, the third and less common form of this disease is mucosal Leishmaniasis. This form can arise from the cutaneous form that can be found in parts of Latin America, since it is possible for the parasite to spread from the skin and cause sores in the mucous membrane of the nose, mouth, or throat. Here is a general list of Leishmania species that can cause human leishmaniasis, along with its clinical manifestation, distribution, and transmission cycle. The life cycle of Leishmania begins with its infective stage. During this stage, the sandflies inject the promastigos of the protozoa from their proboscis during blood meals. The promastigos that reach the puncture wound of the sandfly bite are phagocytized by mononuclear phagocytic cells. This promastigos transforms in these cells into the tissue stage of the parasite, also known as a mastigos. It then multiplies by simple division and proceeds to infect other mononuclear phagocytic cells. The parasite is then transmitted from host to vector by ingesting infected cells during blood meals. The amastigos transform into promastigos in the sandfly gut, which then migrate to the proboscis, where the cycle may begin again. For the epidemiology of leishmaniasis, this disease can be found in 90 countries in the tropics, subtropics, and southern Europe. It is more prevalent in poor developing countries and rural areas. The distribution of visceral and cutaneous leishmaniasis over the last 10 years is shown at the top and bottom figures respectively. It can be observed that visceral leishmaniasis is most rampant in India and Brazil, with approximately 90% of new cases being reported here and in a few other countries. On the other hand, the high number of cutaneous leishmaniasis is more widespread, with around 90% of the world's cases in Brazil and Peru. The clinical manifestation of leishmaniasis differs by form. Cutaneous leishmaniasis arises in the form of skin lesions that can persist from months to years. These ulcerative lesions have a raised border and a central depression and may be covered with a scab or crust. Visceral leishmaniasis, on the other hand, causes fever, weight loss, swelling of the liver and spleen, low red and white blood cells and platelet count, and unusual protein levels. Lastly, the clinical manifestations of mucosal leishmaniasis are similar to cutaneous form, but it occurs in the mucosal regions along with symptoms of oral and pharyngeal stress. The treatment of leishmaniasis is highly recommended by the CDC to be on a case-to-case basis, since the treatment approach depends in part on host and parasite factors, as well as Leishmania species or strain, and the geographic area where the infection was acquired. Treatment for cutaneous leishmaniasis includes systemic parenteral and oral therapy and local therapy. An indication of a therapeutic response is the decrease in induration, or the flattening of lesions. For cases of visceral leishmaniasis, liposomal amphotericin B and pentavalent antimonial therapy are highly recommended and effective. In addition to this, intercurrent infections, which are common in this form of leishmaniasis, should be treated along with the disease. As of recently, there are still no existing vaccines or drugs available for the prevention of leishmaniasis. The CDC generally recommends that the best way to prevent infection is protection from sandfly bites by utilizing personal protective measures. That is all for the phylum Euglenozoa, and thank you for listening.